All right, I think we'll go ahead and get started, everybody. Hello, Dr. Scott Sigman here, representing the godfather of orthopedics, Ira Kirschenbaum, for another open mic session of Joey. It's an absolute pleasure to be here with my dear friend and colleague, Dr. Michael Redler, who is another devout opioid-sparing superhero. And we're going to have a special guest star with Frank Lee, who's the CEO of Pacira Biosciences, to give us his take on the No Pain Act as well. It's really quite remarkable. I think this has been one of the most impressive, arduous legislative victories for healthcare since I've been a physician. Most of us that have been a part of this No Pain Act have been taking the trips and lobbying to Congress for over a decade for what seemed to fall on deaf ears for really decades and for such a long amount of time. Rotten tomatoes every time we walked into another empty-filled lecture hall to be able to talk about opioid-sparing philosophy. And now here we are on the verge of having the federal government recognizing that opioid alternatives are the way to go. So what a pleasure it is today to give an update on the No Pain Act as far as the process is concerned. I'm going to play this video. I hope everybody can have their volume up. Hopefully you'll be able to hear this.
Once you've found the right doctor and have told him or her about your pain, don't be afraid to take what they give you. Often, it will be an opioid medication. Some patients may be afraid of taking opioids because they're perceived as too strong or addictive. But that is far from actual fact. Less than 1% of patients taking opioids actually become addicted. And any drowsiness that might occur when you start to take the medication will soon wear off in most patients.
So that was an actual commercial from 1998 by Purdue Pharma at the start and the height of this opioid epidemic that we all fell into. And it's just absolutely amazing to me, sort of the influence that this had over us across all of healthcare and how we had been so negatively influenced by this process. And as we all know, what had happened was we were following all the rules. We were all good people trying to do the best that we could. And we just didn't even realize it, but surgery became an inadvertent gateway to the opioid crisis and the opioid addiction. And so, we slow but sure started to come up with concepts and ideas about how we could try to lobby Congress and try and change the way we do things. There were so many different ways in which we did that. Many of us went to Congress, to Washington to lobby. Paul Sethi with Grant Hill was involved in the Plan Against Pain. I was with Gabby Reese as well. We all know Adam Brueggemann, who is the advocacy expert for the American Academy of Orthopedic Surgery and Voices for Non-Opioid Choices. The bottom line was it was a really difficult process for us to get in front of these people to explain to them that the opioids themselves were part of the process as to how this addiction was happening and how it spilled over into mainstream healthcare as well. And so it's just, with amazing satisfaction that we're here today. And really what we wanted to do, as all legislative updates, there's a lot of the devil's in the details. There's a lot of nuance to these things. We wanted to share, we don't want to bore everybody too much, but we're going to share about 14 slides just to sort of give the concepts of what the No Pain Act is about and why. And then we'll have Frank Lee give his perspective as the CEO of Pacira, who is actively involved in the No Pain Act and as far as reimbursement for Iovera as well as for Exparel, to give everybody some ideas. And then we want to open it up to the floor. We want everybody to have conversation, be able to share their opinions and ideas as to why this is so important for where we are. So the No Pain Act was brought in front of Congress and signed by President Biden as part of the Consolidated Appropriations Acts of 2023. The idea was, again, non-opioid prevention, addiction to the nation. The aim was to promote the use of non-opioid alternatives. As we all know, we all knew that non-opioid alternatives were working. The problem was they were significantly more expensive than the opioid options. And there were silos in the pharmacies and trying to convince healthcare plans to be able to understand why this was so important. CEOs of hospitals who had ERs and ICUs filled with opioid overdoses, yet weren't willing to spend money on opioid alternatives because it was busting their pharmacy budget. It was really a broken system and really did not make sense. So the idea was to promote the idea of opioid alternatives in pain management, particularly in outpatient surgery, right? What are the three words we hear of with outpatient surgery? ASC, ASC, ASC. If we're going to send our patients home on the same day after surgery, where we used to keep them in the hospital for 3 days, you got to make sure that their pain's under control. And that's really the concept here. That's why the big push in particular has been towards the ASC. So again, focusing with orthopedic surgeons, that's who we are, manage a significant number of these patients. And so we were uniquely affected by this legislation. The key objectives of the action for orthopedic surgeons in particular, number one, was to reduce opioid use. The key is, though, you can't just reduce opioid use and then expect patients to not have pain. You have to address their pain as well. So conceptually, that's where these opioid alternatives were born from as well. And we will talk about some of those that have been included at this point as well. But these things hurt. Joint replacements, fractures, rotator cuff repairs, et cetera, have been traditionally very painful surgeries. And what's amazing now is that we're operating on these patients and they're now opioid free, and some of the most difficult or pain-producing surgical interventions, at least traditionally, that we know about. And the idea was also to expand reimbursement, right? Let's let Medicare and Medicaid cover these opioid alternatives so that we can reduce the overall cost and burden to the healthcare system on the management of patients that are having substance use disorder or having acute opioid crises, et cetera. And then again, most importantly, giving back to our society, combating the opioid crisis. As orthopedic surgeons, we had high post-operative opioid use. We knew that. We were a part of this problem, and so we needed to curb it and come up with solutions and ideas. Additional goals to ensure no financial barriers to providers from using opioid alternatives. The conflict of interest that was associated, even, for example, in bundled payments, for example, for joint replacement, which sounded like such an amazing idea, right? We're gonna provide value-based, care for our patients. But guess what? If we started using things that cost more, there was a conflict of interest to the doctors. They were going to get paid less on the backside. So that had to be pulled out. That had to be carved out to understand the process as well. And then key inclusion. Now everybody raises their hand. Great. CMS and Medicare and Medicaid is going to pay for all non-opioid alternatives. Well, that's not the case, right? There has to be some scientific basis behind why these are going to be used. And so it has to be shown in a clinical trial or published within a peer-reviewed journal that these new opioid alternatives are going to work for CMS to want to be able to pay for them. And again, the idea and concept is to provide separate payment for these opioid alternatives in the ASC and HOPD settings starting this January 1st through December 31st of 2027, hopefully beyond. At this point, we're going to go ahead and pass it over to Dr. Redler to go through the next slides for us, please.
So that's a great introduction, Scott. And before we go to the slide, you have to give a shout out to Scott Sigman, who was one of those guys who was down there in Washington, D.C., was talking to the people, and it was a salmon swimming upstream. And we know that. And we finally have got this victory with the NOPAIN Act, but it's only a victory. We haven't won the war, and there's still a lot more to do. So what are the changes? Because there's an awful lot of orthopedic surgeons or people who are related to the orthopedic surgery world here on this call today. And so the most important thing is separate reimbursement for non-opioid treatments. Scott talked about the bundling idea, but basically now under Medicare and Medicaid, non-opioid treatments used in orthopedic outpatient procedures, and that doesn't matter whether it's in the hospital-based system or an ASC, are eligible for separate reimbursement. And that's so important because, one of the challenges, especially with ASCs where sometimes the margins are thin, is the ability to be able to use these medications, these different treatments that are going to minimize opioid use, but not cause a loss when there's narrow margins to start off with. So basically, it enhances financial viability. Bundled payments are adjusted, just as Scott said, so that you'll now have a carve out for non-opioid pain management alternatives without financial burden. And the important thing is it's for an ASC or if it's an HOPD is covered under that legislation. And so it's seamless between the two. We can go to the next slide, Scott. So listen, we know what we're up against and what we're trying to do. We're trying to improve patient outcomes. And it's no new news here, the fact that we know that use of opioids is causing all kinds of issues. We know that 3 out of 4 addictions probably started with an opioid medication. We know the side effects. We know the constipation. We know the nausea, and we know the sedation. We know readmission for breakthrough pain. And so this is really all about patient care, but doing it in a fashion whereby we can financially be on an even playing field. Addiction is something that orthopedic surgeons don't like to talk about, but frankly, in years past, we were probably part of the source of that as well, because an awful lot of it starts, one, with patients are taking the medication, but it's also the casual use. And we know that it's the medication that's left over because too much has been prescribed. It's in the medicine cabinet. What happens? It's the curious teenager, it's the neighbor, it's the whoever comes in and sees there as well. So it's not just the patient as well. And basically the bottom line is with these opioid sparing strategies and with this new program, we can have enhanced recovery programs, which will allow us to do bigger surgeries, get patients out of the recovery room more quickly, and so it's a win-win situation. Next slide. So as of July 10th, 2024, and this is going to start actually January 1st of 2025, we have an expanded reimbursement, and there's a small list of what is approved now, what we're hoping to be expanded. Scott mentioned earlier, because all of this will be based on studies. You have to have some data to support it. So those of you who have some things that are going to work, we need to get that published. JOEI may be a very good choice for that. Yes, Ira, I hope you're still listening. It's going to be adjustments to CMS payment, direct orthopedic pay, because we use so much in the way of different modalities to try and minimize pain. And basically the bottom line is we're going to go through a list. We're going to talk about some different things in terms of what we're able to use now and what we hope to be able to use in the future. Okay, so right now, and this is the list as we speak right now. Liposomal bupivacaine, Exparel being a fine example, bupivacaine meloxicam, which was Zinrelief, ketorolac, on-Q pump, iovera, Sprint PNS, which is peripheral nerve stimulating system, as well as cryo nerve block therapy, are all on that list. Disposable electronic infusion pump. So these are on the list right now. What we hope is to expand it. You need to have the data to do so. We're going to talk a little bit about the payment structure of how that's going to work for ASCs and how that's going to be functional. So what's our goal here? You want to integrate, start using more of these non-opioids. You can do it in ASC. Your ASC is going to get reimbursed. There's no longer that blockage. This is too expensive. You're causing increase in the cost of care. And what we need to do as orthopedic surgeons and as the orthopedic community is stay updated with it, stay on top of it. That's a minimal list. We know there are a lot more things out there that can also be helpful. This is a start. We have to have data to demonstrate that it's efficacy. And then, as Scott says, right now it's a 3-year plan. What we hope is that it goes in perpetuity. We've got to demonstrate the success of it.
All right, perfect. Thank you, Michael. Outstanding job as always. I just have to sort of get this out of the way. Give me one sec, guys. I'm sorry. There we go. So basically, in conclusion, then, as we're going to sort of turn over the mic here to Frank Lee in a few minutes, but the NOPAIN Act is going to offer significant opportunity for orthopedic surgeons, as well as our anesthesiologists, to adopt safer non-opioid pain management strategies with the broader efforts to reduce opioid dependency with reimbursement incentive. And I can tell you, despite the fact that, everybody that's on this call and is a part of this strategy and what we've been doing, there's just a lot of people that are unaware still. And it's really surprising how many healthcare providers don't have any idea, number one, that the NOPAIN Act is coming on board. They don't want to hear about reimbursement for these things because it's more work for them. They have to carve it out, this, that, or the other. So there's a lot of work for us to do to be able to share what's happening here and why this is so important for the broader public as it is as well. So the call to action is we're going to engage. We want to explore these opioid alternatives. We want to contribute to the policy, continue to lobby, continue to educate our fellow healthcare providers. And so that's really the gist of what we had to say. So Frank, I'm going to go ahead and give you the opportunity at this point. We have a few slides for you to share your thoughts as the new leader in this area, as the new CEO of Pacira Biosciences.
Well, thank you, Scott and Michael, for the opportunity. It's absolutely my honor to be here with you tonight. And my honor to lead a company called Pacira, which many of you may know. And I'll tell you a little bit of background on me is I was happily retired after 30 years in the life sciences industry and happened to come across a company called Pacira and didn't know much about it. And what I saw in the company was a company with a great portfolio of products, as you all know, Exparel, Zilretta, and Aloe Vera. But importantly, what I saw was a leader in this space, as demonstrated by the story I heard about the company working with the community, this community, with the Voices Coalition and many others to champion this No Pain Act. And it's a rare thing to see a company stand up like this. And I heard the story about the 7+ year journey that it took, getting knocked down, being stood back up again, and really fighting for this cause. That's very, very important. So that was super inspiring. And in fact, in my diligence of the company, I happened to come across a video that was made called Gateway. And Dr. Redler referenced that earlier, that these surgeries can be a gateway to addiction. And I watched that with my family, and I said, you know what? As my last job in this industry, before I retire again, this is a noble cause. And I signed up, and I haven't been disappointed since. And so I signed up in January. It's been a tremendous honor, as I said, to work with this team, with this community. And I'm so excited about what's ahead for us, because after all of this work by so many people for several years, 7 to 10 years worth of work, now we're on the real precipice of this happening. And Michael, you said it well, which is this is a great first step, but it's not the end of the journey. And this is what I'm here to talk about is no pain. What we've done is to make sure, working with the coalition, that we bring it to fruition as of January 1, 2025. But I have to say, per the comments earlier, we're making good progress in terms of raising awareness, raising the knowledge and call to action. But we've got a lot more work to do. We've got a lot more work to do. And it's important. And so what we're trying to do here is raise awareness. You can see this No Pain Pact. And if you've been on various websites and other things, you'll see it. And so we've made quite a bit of an investment here to make sure that there's awareness. But even so, it requires all of us now to contribute, not only to be aware, but also take those steps in our respective institutions to educate folks around us, and also importantly now to take action. Because this is a 3-year horizon, and we've got to make sure now that we collect the data to convince those involved that this should be sustained for a longer period of time, and also perhaps include a wider array of products as well. So next slide. Specifically, I'm super happy to share with you that for the first time for Exparel, we have a J code. And as you know, the world operates off of J codes. And so coinciding with the No Pain Act, January 1 will be the J code for Exparel. And all of this time now, Exparel has been coded through more of a C code, which is, as you know, more of a temporary code. And so this is going to ease billing and reimbursement, and now simplify a lot of those things that may have been a bit of a barrier going forward. So bottom line here is, as you can see, with the J code, with no pain reimbursement for these types of patients, it's ASP plus 6%. Next slide. So this is really it. And so I feel like so many have contributed to getting us here, including many of those on the screen. And now it's very, very important. And we're doing our part here as Pacira. We've made a tremendous investment in our field force, in our reimbursement team, in our payer team, in our home office team, to make sure that we can help the community be aware, be educated, and help the community take action. And importantly, take action so that we can really get this opioid addiction issue, this problem, to where it's not hurting our society as much as it still is. It may not be getting as much attention as it once did, but the problem still rages out there. And I know that amongst the Pacira folks and employees, we're very much motivated by our mission to help patients with non-opioid alternatives. And we're doing that. Stop here and thank you for your support, and thanks for the opportunity to say a few words.
Frank, I think that that's great. And I think one of the things that's really important is everybody on this call has a greater level of awareness. But the bottom line is education, education, education is going to be so important. Those are your colleagues, those are the surgical center, those are insurance carriers, and you need to continue because we're all aware of it. The fact that you're taking time on a Wednesday evening to be on this call is a feather in your cap, but there's so much more that we need to do to make people aware. The fact that you've got a J code is great. The fact that you can get a positive reimbursement is great. And so we should all be on a mission in this regard.
Yeah, and you know what? I empathize with folks who are working every day to help patients. They're so busy, time constrained, and there's a lot of barriers out there. But this is an important thing. It's an important act that we need to make sure that we're all working together to raise awareness and education, importantly, taking action. And so it only takes, one or two steps here for us to, each one of us, to influence a couple, three other of our colleagues, and that'll spread. And so look for us to continue to invest behind this in terms of a lot of the things that we're doing, both from a people standpoint and also non-personal kinds of initiatives. But we're certainly with the community and making sure that this No Pain Act has the impact on patients that it's intended to do.
Awesome. Thank you so much, Frank. Really appreciate you being on. So we thought we'd open this up at this point now and really, try and make this a conversation. Looks like we have a couple of things going on in the room there as well. Let's open up. Lara, I'm going to call on Lara Wynn, the Batwoman. I want you to sort of give us an idea here a little bit about what you see as some of the future developments in the No Pain Act for devices that you think are going to make a difference for our patients.
What's interesting is the No Pain Act, it clears a pathway for reimbursement and payment for non-opioid drugs and devices. So CMS just a month ago finalized the 2020 rule and added additional products. So there are a total of 10 products that are now approved for separate payment under No Pain in the ASC and the HOPD setting. And that includes several products that are devices. So one is peripheral nerve stimulation, which has not been used before in the acute care surgical setting because the devices were too costly. So this will make an impact and a difference. Products like iovera were not reimbursed. Now there is a separate payment for products like iovera. And I think this is really something that we hope will stick beyond 3 years. I think right now CMS is proposing that these payments will take effect January 1st, 2025, and they would take effect for 3 years. I am hopeful that this legislation will continue beyond that time period. I think it's important we keep on lobbying. And also, I would encourage everyone who is, in a health system to make sure that their billing and coding teams or their revenue cycle management teams are teed up to have these codes ready and loaded on January 1st so that you're getting paid appropriately for choosing to use opioid alternatives in your practice.
Oh, that's great, Lara. Thank you. So I'm going to open this question up to everybody too. Marty, we're going to get to your point too. I do see it. So what's our expectations from commercial payers, right? We know that they typically follow along the lines of CMS, but is there anyone online that wants to raise their hand and give a perspective as to what we see the commercial payers going to be following or not?
Joe Terry? I think commercial payers often follow CMS. That will be interesting. I think TRICARE always follows CMS. So we expect TRICARE to be on board, if they're not already, right away with no pain reimbursement for opioid alternatives. Joe Terry, I think of calling on you if
Well,
you're on the.
I'm not sure if Joe's on, but
I'm on.
there you go.
Yeah,
Okay.
the only comment I would make, Laura, thanks for calling on me. It's always nice to see you. Is that, there's also a number of commercial payers out there that follow Medicare methodology. So you would hope to see them jump on as well.
I think the important thing here is don't be presumptive that you're in the ASC setting and that your commercial carrier is automatically on board. So I think doing the extra legwork essentially early on is going to be really important to ensure that seamless care. And I think it's going to happen, but I don't think it's necessarily going to happen overnight. Laura, you and I talked offline earlier about how the rates are determined in using the 5 most common high acuity procedures in terms of determining race. And I think for this crowd, for this audience, it'd be really important to hear that.
I think, the way CMS is calculating reimbursement is a bit complicated, but they're looking at reimbursing average selling price plus 6%. So for a product like an Exparel, for example, which is priced at, say, depending on the dose, 320 a vial or 180 a vial, and I don't know if those numbers are exact, but the reimbursement expected should be 100% cost recovery for that product. That's also the same for Zenrelef and for On-Q pumps and for many of the other products, but not all of them. So I think it's important to really understand this rule. CMS has issued specific codes for each of the 10 approved drugs and devices. So it's important to have all of those codes loaded. And whether you're billing commercial or CMS, you want to bill these codes when you're appropriately using these products. Now, CMS will be reimbursing for this effective January 1st. That does not mean that commercial payers will be. I would not expect that they will. There will be a curve and a time period until they catch up.
Hey guys, this is Paul Sethi. I'm sorry I'm jumping on late, but I think this is such an important topic. I don't know if you discussed already or made clear before, what are the documentation requirements associated with this code? Does the medication and the exact dosage and administration need to be in the anesthesia record? Does it need to be in the operative note, or where in the medical record is that required? And is there any pre-certification that we're aware of that will be required?
That's a great question. Is there anyone on who works in medical billing and coding who can clarify that, or anyone at Pacira who can clarify that?
I would say one thing that we know is that you're not going to say, because, for instance, Exparel comes in the 10 milliliter, the 20 milliliter. You're not doing that. It has to be actually the milligrams of the medication. So you're not actually doing the milliliters there as well. And I think that you need to make certain that the J code that was discussed at the beginning of this topic, memorize that, use it, pass it along, broadcast it, because that's going to be important as well. Paul, I don't know what you do when you're operating, when I'm doing. So if we're using liposomal bupivacaine, I'm putting it as part of my operative note. If we're using it for post-operative analgesia, I know that anesthesia is doing so as well. So I think that I'm not sure which of those are going to be the absolute imperative for documentation, but if everybody's documenting it, I think that's going to be a winning formula.
Yeah,
Yeah,
and Dr. Sethi, I can
Go ahead.
mute our computer. I can help you with that. Shouldn't require a prior auth for the CMS part. We're working with about 20 EMR companies to actually build a template within Cerner or Epic and others, so that should automatically pop up in the op notes.
Yeah, my billing company for our ASC, Paul, is mandating that we put it into our op note. And so prior to January 1st, we're putting in the C code and the actual milligram usage that we have been using directly into the op note.
Scott, even if it's an interscaling block, we should include it in our operative note.
Yes.
And I would suggest that as the surgeon, you say, we have requested anesthesia to do an interscaling block for perioperative pain comfort there as well. And I think the more documentation you have, the better. It'll ultimately, hopefully, become easier. But I think that you just you over document right now.
For XBRL, I know there is a specific C code and also a specific J code. So I think what's most important is that your medical billers and coders are on board and they can help educate the physician staff to Paul Sethi's point.
Well, Paul said made a contract with a payer and most likely will require additional prior authorization or administrative burden. I think that'll become clearer as time goes on, but what I would suggest is that we know which procedures we're going to need to use this for. And as part of when you're putting the order for surgery, put it in the order that you're going to use these modalities, these medications for perioperative pain control via the NOPAIN Act, and just put it in your Epic or whatever you're using ahead of time. That will give additional time for for it to be cleared, and then there's no surprises there.
Hey, Corey Callendine, what's your experience in the arthroplasty space right now?
None of
Sorry,
my patients have pain, Scott. Sorry for the delay there. No, listen, I mean, the reason why I'm so interested in this call is, these products have largely been cost prohibitive. It's interesting. I didn't know that this is HOPD and ASC codes. This is not applying to the hospital. So I have to think a little bit around that. I think we have to be thoughtful about how we roll that out. I'm always sensitive if I'm treating patients at the ASC and HOPD differently. I just wonder if anybody else has any thoughts about using these medicines at the hospital.
So you're able to use them now, HOPD. So you're able to use these for your outpatient total knee replacements that are being done at the main hospital.
Yeah. I guess that's what I'm saying. I don't know. Like, we have an HOPD at the hospital. That's true. We use XBRL there. I think they bill it out. But then for my inpatient joint replacement cases, this is not separately billable. Am I understanding that right?
It's not separately billable in the inpatient environment. And it's important to know that this is a huge step forward, but that for now, in your you've been able to get XBRL reimbursed in your ASC.
Yeah.
Okay, but now this means it's also reimbursed in your HOPD, but only guaranteed with CMS. So be careful. You don't want to get yourself in any trouble thinking that this is going to be paid for by all the commercial payers out of the gate. That might take a little more time.
Yeah, I think those nuances are important.
I can tell you, even before the NOPAIN Act, I have used XBRL for every single one of my ACLs. Many years ago, when I had more hair and Paul had less gray hair, Scott and I wrote a white paper on using with ACL reconstructions. And one of the things that we have done to ensure that in the outpatient setting, at least before the NOPAIN Act, is we were going to the carriers ahead of time and say, look, we're going to use this ahead of time, getting approval ahead of time. Hopefully, this will now make it more seamless. But I think that extra legwork, which is only going to benefit the patient, and by the way, your ASC, because they'll be out of the recovery room more quickly. There's less chance of a readmission to the hospital. So it's a win-win situation. But I think when you book the case, let them know you're going to plan to use it, and then there's no surprises, and you have a better and more successful and seamless whole pathway for this patient.
Yeah. Dr. Redler, there already is private payers that are paying for XBRL, depending on where you are in the country. So, like you said, you just need to make sure before you use it.
So we're assuming, though, that this is now going to be expanded. There is a lower extremity indication for it, and so we're using it, as I said, for ACLs, 100% of the cases.
Yeah, I mean, it's interesting. I think what happens is that it's a philosophy, right? Certain ASCs early on have baked in an opioid-sparing philosophy into their process, and they just incorporate it in, and others have not, based on the margins and based on what the pay scales are. as far as that, as far as using the material. But, for those of us that have believed, we've been using it routinely for every patient if we can. How about you, Plancher? What's going on in New York, dude? You still in the Camaro? Step out of the Camaro. What do you got?
The KP is balancing.
He's multitasking. He's got Trump on the phone right now for sure, asking for a sponsorship.
So Patrick Maiden has this. What are codes currently being used for it that are being reimbursed? Laura, you want to comment on that?
So there are C codes that are currently being used in the ASC for a few of these 10, not all 10 of these products, but for a few of them. So certainly for Exparel and for Zenrelef. Now, I can't speak to how commercial payers are reimbursing, but what's really important about the NOPAIN Act is it extends reimbursement beyond ASCs, but also to HOPDs. For the NOPAIN Act mandates that CMS separately pay for non-opioid alternatives. So I think what's important is the codes will be stickier. There are J codes, and they're effective in all of your outpatient procedures for your CMS patients. But commercial payers, and I'm sure Roberto knows the landscape of the United States and what geographies, where certain payers are reimbursing. I think this will be a process. I think that commercial payers will eventually come on board. It'll take a lot of work by companies like Pacira, who do great work lobbying with different payers in different geographies to get this work done.
So up to December 31st, it's a C code. January 1st, it's a J code, and that's important. So memorize that J code.
Yeah, and I think John put it in there. If you do build the C code after for a certain amount of time, you will still get paid. So just to make sure everyone knows, but starting January 1st. And Lara, I appreciate that you would say that I would know every single private payer.
No.
I don't. But I know Frank has invested heavily within Pacira to build out that team to be able to help the community to know. So, it's a lot easier now to reach out to
Roberta,
Pacira.
you could steer anyone in the right direction.
Yeah. I'm sorry?
You could steer anyone in the right direction to get that
Yes.
answer.
Yes, you're right.
Just one point of clarity. I mentioned the comments, but I'm afraid if I don't mention it, I'll forget to ask later. Is there only one J code, or are there J codes individual to each of the 10 on the NOPAIN Act list?
There are unique J codes and C codes for each of the products that qualify for separate payment, according to CMS. So there is a unique code for each one. If that's helpful, I'll send in the chat some of the new codes.
Great.
So we know about total joints. We know that Paul, as a pioneer and leader in shoulder surgery, how are you making use of these for your shoulder procedures?
I mean, with respect to using Exparel, I use an interscaling block on every shoulder procedure that I do, and that's an Exparel block. And I think it's in conjunction with an appropriate multimodal approach to the patient, setting expectations before, using appropriate perioperative medications, gabapentin, nonsteroidal, and Tylenol, and then using an appropriate medication afterwards. I honestly also challenge the patients afterwards. I say, look, you don't need to take the pain medicine afterwards. I just did surgery. I just cut off your humeral head. I just drilled a hole in your knee. And I'll challenge them. We used to, in the days of written prescriptions, put the opiate prescription in an envelope and say, break this seal when you need. Now, we can't do that anymore because everything's digital. But I really do challenge them. I only give them 5 pills. And Michael, you've been like that a lot. I mean, I recall 15 years ago, I was at a meeting and we were talking about knee arthroscopy, and people in the room talked about 30 pills. and they looked at me like I was incredulous when I said, no, we don't do that. And you're the only one in the room at that point in time who said, no, you don't need it. So look, it's not just the medication, it's a philosophy, it's a physician, medical team, and patient buy-in. But when you do that, it works.
And I think that's so important for everybody here, and there are so many proponents of that. Is this it's all about minimizing opioid use, getting patient outcome, and minimizing discomfort. And I use the word discomfort, not in pain. And so this is still part of the overall plan in terms of educating the patient, getting them on board, and this is just going to make it easier to minimize opioid use. So it's a step forward, but it's still part of an overall picture that we all need to do.
So Scott, it's Kevin. I'm sorry. I was dealing with some patients, big surgery day, and I apologize if there's resident, but I want to thank you, Michael, and Frank, thanks, who I do know, because you were willing to stick your neck out a long time ago. It's been 9 years when I started, whenever it was Exparel with total knees and partial knees and outpatients. And so I can say to you, as leaders, you have to have leaders sometimes that on that Malcolm Gladwell curve that do it. But you also offered, the company, thanks, Frank, not only in the operating room, something in the office. And I think it is about your company getting the word out, as Michael said. It is a philosophy. And once you become a patient, and I've had 3 knee or whatever, 2 knee and a shoulder surgery, you learn a different perspective. And so I think they should, in medical school, as they practice venipuncture, we should force people to have operations, sham, and then they would change their whole philosophical approach on how to approach patients. But I think careful wording by the attending, not the physician assistant, is important, and that you're going to be okay. It's going to be great. And I think this is the way we do it, just like Paul said, in the shoulder. So it's utilization everywhere, and it's a great approach. And I thank you for bringing this to us.
Hey, Roberto, what's going on with iovera, right? I've been a big proponent of iovera for all of my total knee replacements. I also use it, outside of the perioperative space too. But, one of the big issues has been reimbursement. It's been to be able to get commercial payers to get on board. Do you feel that the NOPAIN Act reimbursement side to iovera is going to open up the market for you?
Scott, I'm not sure I'm the best person to answer that. I'm not on the iovera side, but I do. I think, being that it got included now in the NOPAIN Act, it's going to allow surgeons, to get past that reimbursement issue that we've been having with that product. So I believe that the NOPAIN Act is going to get iovera to be used a lot more in patients, as I think it should be, right?
It brings up a great point in the chat there. Expectations playing a role in the fact that it's called no pain, because the reality is no one's going to be 100% comfortable after any type of surgery. And one of the things that we've talked about, I don't use the word pain, we use the word discomfort, and it's the same meaning, but it's a different thing. And I've talked about for years, and one of the things I would suggest you do is, instead of doing a pain scale, you do a comfort scale. Same numbers, same silly faces. How comfortable are you there as well? And just by using that slight difference in nomenclature, you are going to change the expectations. But as Kevin said, you're going to have some level of discomfort. We're doing everything to maximize your comfort and minimize that discomfort, but it's not, a pain-free procedure.
Just remember, here's a great anecdote, Scott and everyone. So when I walk into the recovery room, many, not all, healthcare workers in the recovery room are trained to say, how much pain do you have? Oh, you got it? Let me slam in the Dilaudid. That's what they do. It's their natural gut response. So we, as healthcare providers, I think, have to, as we come out of the recovery room, I make it no narcotics are allowed to be given unless I'm called specifically. Now, many of you don't want that because you don't want the call. But I think if you do that, that will change the mentality right away in the recovery room. Plus, they'll get out sooner. They're not snoring, until the cows come home and they're staying there for 5 hours. So
Yeah.
be aware. Their natural response is, let me give you the Dilaudid.
Yeah, that's Teresa Bowling's approach too, who's an amazing anesthesiologist as well. And for any of you that do mission trips, Michael and I go down to Honduras. We bring a boatload of Exparel with us, but there's no narcotics. I mean, they just don't exist. And
Zero.
right, Michael? I mean, so you do crazy operations on these people, you give them a regional block, and that's it. That's what you got. There are no more opioids. So
It's
sort of
part of
changing
the
that philosophy.
expectations there as well. Scott, we've got about 10 minutes left in this call. And I think one of the things to say, look, this is where we are. This is what's happening January 1st. What's on the horizon? What can we expect? How can we further battle it? What new products are coming down the line that may, enhance our ability to give comfort, to perhaps bridge that efficacy gap? I know, Laura, you're involved with Gateway Science. To tell us a little bit about what we may expect down the line.
Could you explain a little better what we can expect down the line with new technologies?
With new
Yeah.
technology, exactly.
Yeah.
So what's interesting is Pacira initially did a lot of the great work behind lobbying for the No Pain Act, but all ships rise in high tide, and it appears this postoperative pain is a $41 billion industry globally. It is growing rapidly, and thanks to legislation like the No Pain Act, there will be a race for new options that are for non-opioid alternatives for pain relief. So I think we can look forward to seeing a number of innovations in this space, whether they're something entirely new or a new application for a therapy that already exists for orthopedic procedures. I think that there are a number of companies that I'm watching very closely that I think will make an impact in the future. I think that the new frontier really is extending pain relief beyond just 3 days. Right now, Pacira's Exparel and, Heron's Zinrelef, the OnQ pump are all designed to provide around 3 days of pain relief, but there's a therapeutic gap. After those 3 days, that's when patients are still relying primarily on opioids for pain relief. And we know that after major orthopedic procedures, pain can last for weeks, not just for days. So I think companies that are focused on that therapeutic gap will make a real difference. I know that, Pacira has in their pipeline a gene therapy that could be a real game changer. And so we're all watching very carefully to see what happens with that technology and how the data pans out.
Hey, Laura, 4 days for the 2 new indications. For the lower extremity indications. So we got another day.
We're getting there.
Scott, don't you have a product you're working with that you're trying to get into the No Pain Act as well?
Who, me in particular?
Yeah, the laser.
So, again, so we're using laser routinely for postoperative pain management, especially into that phase, once you get out of the acute phase with great success. But again, I think I'll hearken everybody back to our original slides, which is, I know I've got great hair and a great reputation, but that's not good enough to get CMS to pay for it. So you're going to have data. You're going to have peer-reviewed data. You're going to have FDA trials and all of it that goes with it. So, we feel that will eventually come, but certainly not on the immediate horizon. But look, there's oral sodium channel blockers that are now, potentially going to be available, which may have similar efficacy to opioids with zero addictive potential, right? I completely agree with Lara that I think that this is going to create a real opportunity for industry as well as for investment into these types of companies that are going to be able to go down through the No Pain Act funnel, if you will.
Yes. Hey, Scott, will you allow Frank to tell us, because I've had the opportunity, some of his thoughts for the future?
Yeah, Frank, please.
Well, sure, I'd be happy to. First off, I just think about what we talked about earlier, which is there's more work to be done. So this act has been passed. It's going to be effective for 3 years. So we need to make sure that we do our best to make sure that patients benefit from this. So that's step number one. Step number two is we're very much committed to making sure we're working with this group and many others about how do we make sure that no pain doesn't just last for 3 years, but it benefits patients for much longer, as it should. And as we think about other products in the pipeline innovation, I think this bodes well for innovation because as companies think about new and innovative products, transformative products, there's got to be a payment method. Otherwise, it squelches innovation. And so I think this bodes well for innovation. And as mentioned earlier, one of the things that we're focused on now, very interesting product, disease modifying gene therapy that's locally administered, is showing some remarkable results out to 2 years. And so we look forward to continuing those kinds of studies into further development and getting more of those kinds of products into the pipeline. So I think overall, this is going to stimulate innovation. But first things first, we've got to make sure that we maximize the opportunity for patients, starting January 1.
Hey, Joe, I think you had a comment to Corey Callandine's issue as far as inpatient use of Exparel. Can you comment on that for us?
Yeah, Scott, thanks. I just wanted to call out a distinction between how specific to Medicare, how they delineate between inpatient and outpatient. So they have IPPS, which is inpatient. They have OPPS, which is outpatient, and they follow the 2 midnight rule. So if the patient stays less than 2 midnights, that falls under OPPS, which would include HOPD reimbursement under the NOPAIN Act. So I just wanted to call that out. Even if you have a patient that you kind of view as, well, they stayed overnight or they didn't go home the same day, they might still qualify as OPPS reimbursement as following that 2 midnight medical.
I think that's a really important distinction because I think that probably gets you another, maybe 20% of your patients, right? If you're doing 50 to 60% at the ASC and then you're bringing the other 40% to the hospital, most of them only need one night and then they're either going home. So then they still fall in to the HOPD category. So I would be screaming that from the rooftops if I were executives that had a company that had a product that qualified for the NOPAIN Act.
Yeah, this is a critical issue because it's not site of service, it's how you treat them. And so just to put it in different terms, I want to clarify what you said. If they're observation status, right, 23 hours, or there are all these other terms, but if they're observation status, so if they're not an inpatient, but the setting is the hospital, you think that would still qualify for reimbursement under the NOPAIN Act?
Yes, it should. I actually learned this in a conversation with the health system a couple of months ago, having this discussion. A health system down in Florida, they said to me, well, the 2 midnight rule is what delineates between IPPS and OPPS. So we bill everything as OPPS if they stay less than 2 midnights. So that means that's under HOPD billing. So that means all of this reimbursement qualifies there if it's done in the hospital. And then I worked back with our reimbursement team here at Pacira and verified all that.
So we're coming up towards the top of the hour to use an Ira Kirschenbaum line. And so I think what we want to do is to have some closing comments. I applaud everybody for being on this call because that means that you're all pioneers and so interested in maximizing patient comfort and minimizing opioid use. I think that January 1st is not going to be, everything's going to be perfect. And so I think that extra documentation, as Paul has discussed, is going to be really important to make certain that we get reimbursed. But Scott, you have some closing comments you want to give us here?
Yeah, I mean, I think as we are all leaders in the opioid sparing space, this is clearly a victory for us, as Michael has clearly stated. There's a tremendous amount of work that still needs to be done. We have to get the commercial payers to come on board. We have a tremendous amount of education that has to happen for our healthcare providers on the anesthesia side, as well as on the surgeon side, as well as our hospital administrators to understand that these things are for real. And so we have a lot of work to still do is the bottom line and the great message, but what a great start.
Paul, any closing comments you want there other than the prayer sign?
Thank you, guys. Amazing talk.
Kevin, anything you want to tell us here?
I encourage the pharmaceutical companies to help us. We need help. And I'm excited that Frank's going to take the charge of Pacira and new gene therapy. I'm ready. I'm an early adopter. I'm ready.
So I think the bottom line is I think a great thing to do is it is 6 months from now, which means we'll be almost 6 months into the No Pain Act. Let's do this open mic again and see where we are. Beth Best, you're on there. You can make that happen. Ira, if you're still listening, if your train hasn't pulled into a tunnel, you're listening there as well. But I think that this is an ongoing saga. Let's have a lot of, there's Ira. He's still on the train. He's gone. At any rate, but the point is, I think let's come back to this topic again because I think that we're on that upward surge. As Frank has said, we're still in the battle. We still may be salmon swimming upstream. The current may be not quite as strong, but we still have a lot of work to do and see where we are from there. And I just want to thank everybody for taking your time tonight for this topic that I think that we're so passionate about.